coagulopathy and antiphospholipid antibodies in patients with COVID-19. Introduction. Infection with the SARS-CoV-2 viruses causes the clinical disease COVID-19. In severe cases of COVID-19, patients may develop acute respiratory distress syndrome and multi-organ failure. Systemic inflammation caused by direct viral infection of tissue and severe coagulopathy are proposed mechanisms contributing to multi-organ failure. Indeed, COVID-19 associated coagulopathy may be a key cause of morbidity and mortality in critically ill patients. Coagulopathy associated with COVID-19 is characterized by elevated levels of D-dimer and derangements in coagulation times. Recent reports describe antiphospholipid antibodies in COVID-19 patients who suffer multiple thrombotic events. Very few of these reports include individual test details or evidence of persistent antiphospholipid antibodies.
In the same diagnosis. These antibodies that I just mentioned are not in the blood for the vast majority of people. These antiphospholipid antibodies are bad because they attack the phospholipid proteins in our body, and if it's severe enough, they can cause major clots to form in our blood vessels. So antiphospholipid antibody syndrome, it's a condition that depends on someone's genetics, but these antibodies can also arise transiently in patients with critical illness and various infections. So do all patients with COVID-19?
Implications in medicine. A 69-year-old man with a history of hypertension, diabetes, and stroke precedent with fever, cough, dyspnea, diarrhea, and headache, COVID-19 was diagnosed in the patient on January 25, 2020 on the basis of the PCR testing that detected the SARS-CoV-2. The initial treatment was supportive, however, the illness subsequently progressed to hypoxemic respiratory failure, warranting the initiation of invasive medical ventilation. Demographic and clinical characteristics and laboratory findings. On examination, the patient had evidence of ischemia in the lower limbs bilaterally, as well as in digits 2 and 3 of the left hand.
So another really good question, one where there's quite a bit of research actually being put out there, and one that we've already at the Thrombosis Research Group been engaged in trying to look at this. So it looks like COVID-19 has a number of ways that it impacts blood clotting. When patients contract COVID-19, if they suffer a superimposed either pneumonia or other type of bloodstream infection, they have the risk of going into something called disseminated intravascular coagulation, or DIC. And that's a condition that's associated with bleeding. You consume your platelets, it becomes harder and harder for the body to stop bleeding, and there's a hemorrhagic response. That's really one of the most severe manifestations of a COVID-19 infection with a superimposed bacterial infection or a systemic inflammatory response. For other patients who suffer,
Hematologists face two challenges in the COVID-19 pandemic. First, they continue to treat patients with the chronic hematology conditions, but now must do so with a focus on reducing infection risk while still providing quality care. Second, as clinical data are rapidly collected and distributed, meaning hematologists are tasked with characterizing and guiding the management of the hematologic manifestation of the disease. The American Society of Hematology has developed a series of recommendations to assist with both.
Cough. They can also have lightheadedness and dizziness, or even temporarily lose consciousness. And some people don't have any symptoms at all. It usually depends on the size of the clot. Sometimes clots can form in the arteries and cause a stroke, or they can lodge in the coronary arteries and cause a myocardial infarction, meaning a heart attack. Or they can cut off blood flow.
Infection with severe acute respiratory syndrome coronavirus 2 was confirmed in all patients by reverse transcript polymerase change reaction assay or serological test. Patients with a history of hypertension, diabetes, and stroke presented fever, cough, dyspnea, diarrhea, and headache. COVID-19 basis on the PCR tests are detected SARS-CoV-2. The initial treatment was supportive, however, the disease subsequently progressed to hypoxemic respiratory failure that warrants the initiation of invasive mechanical ventilations.
Is the H type. H refers to high elastance, meaning lots of stiffness in the lungs. These lungs are very stiff, which does not bode well for lung function. But then there's this other type of ARDS, which the other half of the patients in this study had. These patients' lungs have some of that grayish crap, meaning there's some inflammation going on there, but it's not as much as you would expect given the degree of their hypoxemia. In other words, the oxygen levels are far below what you would expect given the degree of inflammation that you're seeing in the lungs. This type of ARDS is known as the L type, meaning these patients have low elastance, meaning their lungs aren't very stiff. So with this L phenotype, there's something else besides inflammation that is contributing towards their very low oxygen levels. And it can only be one of two things, or a combination of these two things. And that is one, constriction of the arteries that deliver blood to the lungs. In other words, pulmonary vasoconstriction. And this is essentially pulmonary hypertension, meaning the pressure in these arteries is high. This means that there's less blood being sent to the lungs to pick up oxygen, and this by itself can cause low oxygen levels. The second thing is the development of clots within these arteries and capillaries, and this also impairs the ability of the lungs to get oxygen into the blood. So what exactly are blood clots?
A substantial subset of patients with the COVID-19 are dying with a severe TMA, arising in association with viral invasions of endothelial cells and triggering a robust immune response with widespread activation of immune cells, cytokines, and complement activation. The range of clinical, laboratory, and pathological findings reviewed here confirms a diffuse small vessel microangiopathy similar to the complement-associated TMA syndromes.
COVID-19 patients in the hospital are developing blood clots, and should we empirically give high doses of blood thinners to these patients who are in the hospital? So that's what we're going to tackle in this video, but before I dive right in, let's look at a very interesting report that was published based on a study of patients who had severe COVID disease with ARDS. This study was done based on patients in Italy by the famous Dr. Gattinoni, who I think of as the godfather of ARDS. I mean, this guy was publishing research articles about ARDS while I was still in diapers. Let's start off by taking a quick look at what a normal CT scan of the chest looks like. Black represents air and bone is white. If the patient receives IV contrast, the blood vessels will look white. But the important thing to notice here is that the lungs are normal. Now, let's take a look at Dr. Gattinoni's study. What he found in his study of COVID patients with severe ARDS is that there seems to be two types of ARDS. First, take a look at the PO2 to FiO2 ratios of the patients in the study, where it says 95 millimeters mercury and 84 millimeters mercury. These are extremely low levels of oxygen. These numbers are telling us that these lungs in these patients are having a very difficult time getting oxygen into their blood. In half the patients in the study, the patients had the typical ARDS that we all know and hate, which causes tons of inflammation with fluid and debris filling the alveoli, where the chest x-ray and the CT scan of the lungs looks horrible. This is depicted in the bottom CT scan. Let's take a closer look. Look at all